This lecture will cover physical development in infancy. With regard to physical growth and development in infancy, we'll first begin to discuss growth patterns, then we will move on to the brain. We'll also be discussing sleep patterns in infancy, as well as the topics of sudden infant death syndrome and nutrition. We'll then move on to motor development in infancy, where we'll discuss reflexes and motor skills. And lastly, we'll discuss sensory and perceptual development in infancy. This table outlines the basic growth patterns throughout the first 2 years of life. The average weight for a newborn baby is 7 pounds and an average height of 20 inches. If a baby is born at 6 or 6.5 pounds, they are just slightly below weight. If they are born above 7 pounds, then they are above average weight. It's not really a cause for concern until the baby is born under 5 to 5.5 pounds. At that point, we begin to become concerned. Typically, low birth weight is associated with premature birth or maybe exposure to teratogens such as tobacco or high levels of caffeine ingestion. During the first year of life, babies triple in size, or tries to say triple in mass. They go from about 7 pounds on average to about 20 pounds on average, and they also grow by about 10 inches. So we see rapid extreme growth during the first year, and that growth trend continues into the second year, where they typically gain an extra 10 pounds as well as grow an extra 5 inches. If a baby is failing to put on weight during the first 2 years of life, that can be a cause for concern as well. There can be some genetic reasons for that, as well as some general nutrition reasons, such as being malnourished. There are 2 different growth patterns that babies experience, or that all humans experience regardless of their age. That is cephalocaudal growth and proximodistal growth. So cephalocaudal growth is essentially from top to bottom. The term cephalo implies head. So for example, the term microcephaly is a term that's used to describe one of the symptoms associated with babies who are affected by the Zika virus. Microcephaly implies small head. Hydrocephaly implies water in the head or water in the brain. And an electroencephalogram is a brain imaging technique in which we measure the electrical activity in the brain. So cephalo implies brain or head, and then caudal implies tail or our feet essentially. And so that growth basically describes the top to bottom growth. Proximal distal growth is from the center of the body towards our extremities, towards our arms and our legs. So we are constantly growing in all directions. With regard to brain development in infancy, it's important to understand that babies are born with over 100 billion neurons at birth. However, there are not a whole lot of existing connections within these neurons. Through environmental stimulation, that is where neuronal connections are formed. And it's important to understand that neuronal connections are essentially the physiological foundations for all aspects of our psychology, for our movement, for our decision making, our memory, our emotions. We are born with some neuronal connections, and that's going to be displayed or exemplified when we discuss reflexes. Now, it's important to understand that just like how we can form connections between neurons, neurons can also die as a result of physical trauma or a lack of stimulation. And then that essentially, any neurons that die, well, the connections at which they're a part of are also going to essentially disappear or disintegrate. One of the most common examples of physical trauma of babies is known as shaken baby syndrome. This occurs when a caregiver, typically a young and impatient caregiver that's prone to aggression, becomes very, very irritated by the crying sounds of a baby, and out of frustration they will shake the baby, and what ends up happening is the baby's brain is still very, very fluid and very, very soft and fragile, and when they shake the baby, because the baby has no neck support and they have very, very weak muscles in their neck, their head will basically move back and forth violently, shaking the brain inside the cranial cavity, which will result in some severe concussions, and ultimately that will result in brain damage. Oftentimes we see damage to the optic nerves, but the damage can essentially be in all different parts of the brain. Typically, these babies will experience issues with vision, maybe even with language and motor delays as well. The brain's ability to form neuronal connections or neural connections is known as neuroplasticity. Even if we experience brain damage of any sort in life, through the process of physical rehabilitation and physical and occupational therapy, the brain can rewire itself and reform some of the connections that it lost. However, as we discussed in the first chapter of this class, development is plastic, and so therefore any traumatic experiences that we have, such as shaken baby syndrome or major concussions, those are going to have a lasting permanent impact on our development. Yes, the brain can relearn and retrain itself and rewire itself, but it's always going to have signs of damage. We have two images here. The image on the left shows a neuron. It's a graphic of a neuron, and along with all the different structures that are of the neuron which are identified. So the dendrites, which are the branches on the left side of the neuron, these are responsible for receiving incoming messages from other neurons. Neurons communicate with chemicals called neurotransmitters, such as serotonin, dopamine, norepinephrine, GABA, glutamate. There's hundreds of neurotransmitters that have been identified. The ones that I just mentioned are just the most well-researched and most well-understood. So dendrites, they absorb neurotransmitters from the synapse or the synaptic gap. The synapse or synaptic gap is essentially the space between all neurons. So when a neurotransmitter releases chemicals through the axon terminals on your right, those neurotransmitters are released into the synapse or the synaptic gap, where they can be absorbed by the dendrites of all of the other surrounding neurons. Neurons have an electrical charge to them. When they absorb neurotransmitters, that can either increase or decrease the electrical activity of a neuron. Once the neuron reaches a certain level of electrical activity, it will fire an action potential or a burst of electricity down the axon. As you can see, the axon is covered in something called a myelin sheath. A myelin is essentially a fatty substance or a lipid that is meant to provide insulation, so that way the electrical impulse can be smooth. In the case of a neurological disorder such as multiple sclerosis, in that case, the autoimmune system of the body actually attacks the myelin sheath and deteriorates it, and that can result in issues with the electrical impulse reaching the axon terminal. And depending on what part of the brain is affected, that is ultimately going to determine the symptoms of the individual that is experiencing or is diagnosed with multiple sclerosis. So keep in mind that the neuron is a cell, and therefore it has a cell body and a nucleus. It requires oxygen and sugar to survive. When people are deprived of oxygen, their neurons will die. When people experience concussions or any sort of physical trauma, neurons will die. And when neurons die, they essentially they can't be replaced. However, we can, as I was saying earlier, with regard to neuroplasticity, the brain can retrain itself to some extent. On the picture on the right, we see a baby who is hooked up to an EEG machine. The cap that the baby is wearing has a bunch of electrodes that are going to measure the electrical activity in the brain. Those electrodes are connected to a computer, which will essentially graph out the electrical activity. EEGs, electroencephalograms, are commonly used to identify issues with multiple sclerosis or sleep-related disorders. The brain, from a more macroscopic perspective, can be divided into 2 different hemispheres as well as 4 different lobes. It's very symmetrical in the sense that the frontal lobe is shared between the left and the right hemisphere, and all lobes are shared between the left and the right hemisphere. The 4 lobes are the frontal, parietal, occipital, and temporal. They all have many different functions and they all work collectively. However, each of these lobes has a primary function that it is most commonly associated with. With regard to the frontal lobe, it's the most complex and the most advanced of our lobes. It is responsible for not only executing our motor movements, but also for our decision making and impulse control. What research shows is that young children have an underdeveloped prefrontal cortex or a frontal lobe, and so the prefrontal cortex is the most forward part of the frontal lobe, and that's the part of the lobe that's most responsible for decision making and impulse control. It's very underdeveloped with children. Children that are diagnosed with ADD and ADHD who struggle with impulse control and decision making, many of those children show on brain imaging scans that they have a smaller than average prefrontal cortex. The movement aspect of the frontal lobe is located towards the rear of the frontal lobe, and it's responsible for all aspects of motor functioning. So for example, for sending commands to your feet to move or for your fingers to type, those commands are coming from the frontal lobe. The parietal lobe, which is at the crown of the head, is responsible for sensation. So there's a large amount of pain receptors that are located here. When we experience pain, or whenever we experience any sort of sensation on our skin, anything that we touch that we feel is cold or hot or sharp or soft, that's going to send an electrical impulse up to the parietal lobe, and it's going to register there, and we're going to be able to make sense of what we're experiencing. The occipital lobe is responsible for our vision. Our eyes have optic nerves that run through the brain and connect to the back of the brain, the occipital lobe. The brain is actually cross-wired, so the right eye is connected to the left end of the occipital lobe, and the left eye is connected to the right side of the occipital lobe. Also worth noting that when a command is sent from the frontal lobe to move the left hand, that message is coming from the right hemisphere of the frontal lobe. And the temporal lobe is right by our temple. Its primary function is hearing. It contains the auditory cortex. The yellow area that is beneath the cerebral cortex that's displayed on the image on the right, that's the brain stem. The circular part is known as the pons. It's responsible for sleep and dreaming. And then the oblong shape at the bottom is known as the medulla. And the medulla is responsible for physiological functions such as heart rate and breathing and digestion. So damage to those areas can be critical. Although it's not clearly displayed, there's a part of the brain located at the bottom towards the back underneath the occipital lobe. It's shown slightly on the right image in red. That's the cerebellum. The cerebellum is responsible for coordination and balance. And so when people ingest alcohol and their coordination and balance is disrupted, typically that involves neurotransmission in the cerebellum. These graphics display some of the general sleep patterns associated with newborns. So the graph on the top left shows the patterns of sleep and as well as REM sleep and waking state for humans from newborns all the way through 20 years of life, from infancy, childhood, and adolescence. So what we see is that newborns spend about 15 hours a day asleep. And they also spend about half of that time in REM sleep. REM sleep is also known as dream sleep, and we'll be discussing that just shortly. So as you can see, by the second year of life, we are sleeping about 12 to 13 hours a day, and only about 4 hours of that time is spent in REM sleep. By the time we're 20 years old, we only sleep about 8 hours a day on average and spend about 2 hours of that time in REM sleep. So I'm going to go ahead and jump all the way to the image on the bottom right. That is actually an electroencephalogram reading from an EEG machine. And so what we see are these patterns when people are awake and in a relaxed state, like many of you are probably right now as you are experiencing this lecture. We see a lot of quick, rapid bursts of electricity. And then as we enter sleep stages 1 and 2, as you can see, the electrical activity begins to slowly decrease. When we're in deep sleep, we just experience these basically very slow, long electrical bursts, and this is when we are in our deepest state of sleep. However, this is not when we're dreaming. Dreaming occurs in REM stage sleep, and as you can see, the electrical activity is very quick and rapid, much like in our relaxed or waking state. And the reason for this is that when we're dreaming, our brain is providing its own stimulation. It's producing images in the occipital lobe, and it's producing sounds using the temporal lobe. One of the reasons that our dreams often are nonsensical is because the frontal lobe, which is responsible for decision making, is often inactive. And so that's one of the reasons why we can't control what we dream, or we can't guide our dreams to experience what we want to experience. Our dreams are heavily basically based off a lot of the visual and auditory experiences that we had during the day. And there's a lot of memory consolidation that occurs during REM sleep as well. The graph in the middle is just a basic general description of what a typical sleeping day might be for a baby. Now, all babies are different, but as you can see here, the main idea is that babies essentially do not sleep all 15 hours at once. They take a lot of naps throughout the day, and so most of their days actually just spent sleeping, waking up from sleep, eating, and then basically falling back asleep. And so they spend a lot of time not just sleeping, but drifting in and out of consciousness as well. So there's very little time for newborns in which they're actually awake and alert and attentive towards stimuli in the environment. Sudden infant death syndrome is a diagnosis that's given towards babies that die unexpectedly in their sleep. There is no one known specific cause for sudden infant death syndrome, but what we see is that there are some common associations with this, and one of those is heart arrhythmia. Basically, babies that are born with an irregular heartbeat, babies that experience sleep apnea, which is essentially a sudden cessation of respiration during sleep. Babies that are born premature or with exceptionally low birth weight, under 5 pounds, they're much more common to experience sudden infant death syndrome. Exposure to cigarette smoke, so homes in which people smoke indoors where there's a baby, that is also linked with sudden infant death syndrome, as well as heavy bedding. If you'll notice in the image on your right, the bedding for this baby is very firm and very light. There are no pillows, there are no stuffed animals, because and the baby is sleeping on their back. And the reason for this is that, if a baby rolls over onto their face, that will obstruct their airway, and they do not have the strength to essentially rectify themselves, and so they can essentially suffocate themselves to death. With regard to breastfeeding, breastfeeding lowers the risk of gastrointestinal issues in babies. They're less likely to experience diarrhea. They're less likely to develop respiratory infections or get asthma. Breastfeeding is also associated with the lower risk of childhood obesity. It's associated with the lower risk of sudden infant death syndrome, and it also shows to have beneficial benefits towards women in that they have lower chances of breast or ovarian cancer. Of course, mothers should not breastfeed if sick, taking medications, or taking any drugs, because all of these drugs and substances can be transmitted through the breast milk to the baby. It's also important to understand that this research is correlational, and therefore a child can be breastfed exclusively and still develop some of these issues. But what we see is that when children are breastfed, or when breastfed children are compared to children that are not breastfed, as a whole, there are just lower rates of these issues, such as gastrointestinal issues, so on and so forth. However, and lower chances of breast or ovarian cancer for the mother as well. The American Association for Pediatrics, the American Pediatric Association, recommends that babies are breastfed exclusively for the first 6 months of life, which means that they should be eating nothing else other than breast milk. And then, although other substances can be incorporated after the first 6 months of life, it is recommended that breastfeeding continues throughout the first year. Although there is no cutoff time for the cessation of breastfeeding, that is a topic of debate as to when women should stop breastfeeding their children. This magazine cover here is very controversial. It was released, I'm not sure exactly what year, several years ago. It's important to understand that there is a culture of something called attachment parenting, where women breastfeed their children well past the first year. The breastfeeding is not exclusive. Their claim is that it provides more of an emotional bond between the child and the caregiver. There is an argument that says that common sense would dictate that children should not be able to breastfeed once they reach an age in which they're able to ask for it. I think the same logic of common sense would also state that humans have been breastfed for millennia throughout time, and surely there was a time, and there certainly are cultures in which there is a severe food shortage, where breastfeeding was essentially the primary food source and was probably extended well past the first year. And so, although we might live in a culture and era where breastfeeding after the first year is probably not necessary, it's important to understand that there's certainly is likely a culture and an era that exists or existed in which breastfeeding past the first year was probably very common. Move on to motor skill development. So motor skills are developed by, the development of the nervous system. So it's important to understand that when we're discussing neuroplasticity, as the nervous system forms new connections, that is also going to coincide with the development of our motor skills as well. So as babies move and interact with the physical world around them, that is providing stimulation to the nervous system. It's important that children are provided with opportunities for movement, which means that they are put on the ground with objects that they can grab and manipulate. It's important that children are motivated to reach a goal of motor skill development, such as walking, and it's also important that children are provided with environmental support for the skill, such as walkers, which are designed to promote that motor skill development in babies. It's important to differentiate between gross motor skills and fine motor skills. Gross motor skills involve large muscle activities such as crawling and walking. We see a lot of gross motor skill development during the first year of life. During the second year of life, that's when fine motor skills become more developed. Fine motor skills involve our fingers and our lips and our tongue. And so with regard to talking and grabbing things, that is with regard to fine motor skills. We see a lot more fine motor skill development during early childhood when children begin to learn how to write and draw. So it's just important to differentiate between both of these things. This timeline displays some of the milestones in gross motor development. As you can see, children begin to be able to basically only sit without support by themselves at around the 5th month. They can typically stand by themselves at around 6 or 7 months. Of course, they're likely to fall very quickly. They are usually able to stand on their own for an extended period of time, around 10 months, and they should typically take their first steps and start walking alone easily around the first year of life. And so we use this timeline to describe general motor skill development throughout the first year of life. And so when a child is 13 or 14 months old and they have still not began to walk alone easily, that is a cause for concern, and that would be basically described as delayed motor development. And then that would basically lead to some concern and maybe begin to present some questions as to whether or not this child may have some sort of neurodevelopmental issue. With regard to sensory and perceptual development, this field of study basically focuses on the development of our 5 senses. So sensation is essentially environmental stimulation. All of the light waves and sound waves that we experience, the chemicals in the air that we smell, and I don't mean harmful chemicals, just understand that, that's basically the basis of our smell, of our sense of smell. Things that we can touch and feel. Perception is how the mind organizes or interprets all of what is being sensed. The human mind has an ability known as habituation, which has an evolutionary advantage. So we are exposed constantly to different types of stimulation from the environment, different things that we can see, touch, taste, hear, and smell. What the mind is trained to do, or what it naturally does, it becomes attentive to, or it attends to new stimuli in the environment. So if there is a new sound that we are experiencing, or a new feeling of touch, or a new visual stimulus in the environment, we are likely to pay attention to that stimulus. And then after a while, if the stimulus is essentially recurrent and unchanging, we will essentially respond less to it over time. That's known as habituation, and that allows us to essentially focus on new stimulation in the environment. We can only focus on so many things at a given time, and so therefore, as sounds come in and out of our environment, that allows us to focus on things that are changing. And also ignore things that have been present and constant, because things that are present and constant, basically, if they've existed for an extended period of time, they are likely not to be any sort of threat to us. The image on the left basically just shows how vision changes over the first 6 months of life. As you can see, babies have very poor vision at birth. It's not very clear, and also their sense of color vision is not fully developed either. The image on the right displays the baby's development of depth perception. As babies begin to learn to crawl and move around the physical environment, they will establish depth perception. And so this visual cliff on the right is basically used to demonstrate that babies display fear of walking over a glass platform that's been elevated because they are able to perceive the depth and the distance of the ground below it. And so this basically just proves that babies have developed depth perception once they begin to learn to crawl. That concludes physical development in infancy.